Our first episode is all about asthma. Let's start with this topic. Asthma is an episodic chronic respiratory disorder characterized by airway obstruction caused by inflammation and hyperresponsiveness of the bronchial smooth muscle. The two called-in words for asthma are reversible, which means the obstruction can virtually disappear with medications like bronchodilators, and inducible, which means obstruction can occur in response to a variety of stimuli, including allergens like house dust mites, pet animal dander, cat dander, pollen, irritants like tobacco smoke, respiratory tract infections like a common cold, pneumonia, cold or dry air, and even emotional stress. Now, atopy is the genetic predisposition of an individual towards developing IgE antibodies to otherwise harmless antigens, making that individual strongly predisposed to developing these allergic disorders. Eczema, atopic dermatitis, allergic rhinitis, asthma, collectively coined the atopic triad. Eczema, allergic rhinitis, and asthma collectively coined the atopic triad. Because of this genetic component, asthma is usually diagnosed in early childhood and may or may not carry on to adulthood. So, say a genetically predisposed child is exposed to a potentially allergen for the first time. First off, dendritic cells take up the allergen and present it to a type 2 helper T cell or Th2 cell. In asthma, Th2 cells make the mistake of thinking this harmless antigen is an allergen. So they release cytokines that stimulate B cells to make IgE antibodies. IgE antibodies then prime mast cells, which cautiously anticipate the next event. When the child is re-exposed to this allergen, the mast cells spill out vasoactive mediators like histamine and leukotrienes, which cause bronchoconstriction and inflammation. Once the child is no longer exposed to the allergen, the immune system relaxes and everything goes back to normal until the next event. Now, not all asthma episodes are triggered this way by an allergen. A unique form of asthma is aspirin-sensitive asthma, which is characterized by the triad of asthma, nasal polyps, and sensitivity to aspirin or NSAIDs. Aspirin possesses prostaglandin production and tips the balance between prostaglandins and leukotrienes in favor of increased leukotriene production, which promotes smooth muscle contraction of the airways. Alright, patients with asthma have intermittent episodes of dry cough, chest tightness, and shortness of breath. Some patients have just a single symptom like cough, making the diagnosis more difficult. These symptoms usually occur in the daytime but can also happen at night. On auscultation, there will likely be wheezing during expiration because that's when the airways collapse and become narrow. Percussion may reveal hyperresonance, which indicates that the bronchoconstriction has led to air trapping and hyperinflation. Severe episodes are ones where a patient struggles to breathe. They may only be able to speak in short phrases and may need to use accessory muscles like the scalene muscles of the neck or the intercostal muscles of the ribs to help with breathing. But all that wheezes is not asthma. For example, chronic obstructive pulmonary disease or COPD. COPD can also cause wheezing, but it's more common in the older patients who smokes, and in COPD the symptoms are often irreversible because there are permanent changes to the architecture of the lungs. Another one is aspiration of a foreign body, which might obstruct an airway and cause wheezing in one area of the lungs. This usually occurs in young children, and there is often a sudden onset of wheezing and cough along with the history of the child being unobserved or potentially swallowing something. Bronchiolitis or inflammation of the small bronchioles is often seen in children less than 2 years of age and presents with acute cough, wheeze, and shortness of breath following an upper respiratory tract infection like a common cold. Gastroesophageal reflux disease, a GERD, can also mimic asthma with symptoms like chronic cough and wheezing. However, the patient is often an obese adult and symptoms often improve with proton pump inhibitors. Allergic bronchopulmonary aspergillosis or ABPA. ABPA is an allergic response to aspergillus antigens and usually occurs in the setting of asthma or cystic fibrosis. ABPA presents with wheezing and high serum Ig levels and eosinophil counts. However, chest radiographs often show recurrent pulmonary infiltrates. Finally, there is characterized syndrome, which is small vessel vasculitis that's associated with eosinophilia and wheezing. But patients also have skin purpura and peripheral neuropathy. Okay. Now, when asthma is suspected, the first step in diagnosing is conducting pulmonary function tests, PFTs. The most important measurements are the forced vital capacity or FVC, which is total volume of gas exhaled after a forced maximum expiration. After the forced expiratory volume at 1 second, known as FEV1, both of which are decreased in asthma. Both FVC and FEV1 are decreased in asthma. Now, because asthma is an obstructive lung disease, the FEV1 is decreased to a greater degree than the FCV1. So the ratio of FEV1 to FVC is usually less than 80%. Also, because asthma is episodic in nature, the PFTs are only abnormal when the patient is having symptoms. If a person is symptomatic, the next step is to give a bronchodilator like albuterol, which reverses the PFT measurements back towards normal, confirming the diagnosis of asthma. A significant reversal is defined as increase in the FEV1 by more than 12% from baseline. If the reversal is less than 12% after giving a bronchodilator, then the patient is less likely to have asthma. Now, if you do PFTs on asymptomatic patients, they would be normal since asthma is an episodic disease. So, in this case, we try to induce asthma symptoms by performing the methacholine challenge test. Methacholine is like acetylcholine, so it binds to muscarinic receptors on bronchial smooth muscles, causing mild bronchoconstriction. In an individual who is healthy, doesn't have asthma, this bronchoconstriction is negligible and does not have a significant change in PFT measurements. But because an asthmatic patient's bronchial smooth muscle is hyperresponsive, methacholine causes a 20% decrease in their FEV1 from the baseline. Remember the golden asthma words reversible and inducible. Now, some additional tests are not specific to asthma but may help with the diagnosis. A complete blood count may show an increased eosinophil count. Serum IgE levels may also have increased. And skin testing may help identify specific allergens that the patient can subsequently avoid. That involves injecting small amount of known allergens into the patient's skin and then observe to see if the immune system overreacts to it. Okay, so after diagnosing asthma, the next step is to determine how bad is it. Asthma severity is classified as intermittent, mild persistent, moderate persistent, and severe persistent. As the severity of the asthma escalates, so does the complexity of treatment plan, specifically the type of chronic treatment the patient requires. In terms of medications, the first class of bronchodilators, which include short-acting beta agonists or SABAs like albuterol, and long-acting beta agonists or LABAs like salmeterol. The second class are anti-inflammatory medications, which include inhaled corticosteroids like budesonide and fluticasone, leukotriene antagonists like montelukast and gelatin, and oral corticosteroids like prednisolone. The third and final class of medications are mast cell stabilizers like cromolyn. Alright, classification of asthma severity is determined by 4 parameters: the frequency at which a patient experiences daytime symptoms, the frequency at which the patient experiences nighttime symptoms, the FEV1 in between exacerbations, and the degree to which the asthma interferes with the patient's normal daily activities like going to work. Children less than 5 years of age cannot usually follow PFT instructions, so the FEV1 parameter is eliminated. Now, intermittent asthmatics have less than 3 daytime symptomatic episodes per week. Nocturnal symptoms less than 3 months per month, and FEV1 more than 80%, and no interference with normal activity. Intermittent asthmatics can be managed with SABA, given only during the symptomatic episodes. Mild persistent patients experience daytime symptoms 3 or more times per week, but not every day. Nocturnal symptoms 3 to 4 times per month, and FEV1 more than 80%, and have minor limitation in activity. In addition to using a SABA when needed, mild persistent asthmatics are also started on low-dose inhaled corticosteroids, which are administered daily. Moderate persistent asthmatics experience daytime symptoms every day, so 7 times a week, have 1 or more nocturnal episodes per week, but not every night, and FEV1 between 60% and 80%, and have moderate limitation with normal activity. In addition to using a SABA when needed and low-dose inhaled corticosteroids, they are given a LABA as well. However, children less than 5 years of age with moderate persistent asthma escalate their inhaled corticosteroids to a medium dose and no LABA is added. Severe persistent patients experience daytime symptoms throughout the day, have nocturnal symptoms nearly every night, and FEV1 less than 60%, and have extreme limitation in normal activity. In addition to SABA and LABA, the dose of the inhaled corticosteroids is increased in these patients. Children less than 5 years of age may also alternatively use montelukast instead of LABA. In patients with other allergic reactions symptoms such as allergic rhinitis/eczema who may have an elevated serum IgE, the monoclonal antibody omalizumab can target IgE, providing additional benefit to patients who are already on high dose inhaled corticosteroids and LABA. So let's summarize this topic. As a quick recap, asthma is a chronic condition with reversible airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation, all of which lead to recurring symptoms like wheezing. Based on symptoms, patients are categorized having intermittent, mild persistent, moderate persistent, or severe persistent asthma. Treatment plans initially include a short-acting beta agonist, but step up as needed to include stronger medications such as long-acting beta agonists and inhaled and oral corticosteroids. Asthma exacerbations are classified into moderate, severe, life-threatening, and near-fatal. Initial treatment includes nebulized bronchodilators like albuterol and ipratropium, as well as systemic corticosteroids.